Good morning, everybody. I'm happy to talk to you today about an intervention we did at LA General to try to empower staff to do the right thing. The best thing about this intervention is that we got a manuscript published in JAMA Internal Network with a Lord of the Rings title that is all about Dungeons and Dragons. That's by far the best thing about this intervention. And you're like, well, why are you talking about Dungeons and Dragons? What does that have to do with hospitals? I know there's some closeted Dungeons and Dragons players out there. But I'm gonna explain it so you can pretend you don't know. So I'm gonna go through it. It's all good, okay? When you play D&D, you create a character, and you have to decide what kind of personality they're gonna have. You decide, are they gonna be good, neutral, or evil? And that's pretty self-explanatory. But you also have to decide if they're gonna be lawful, neutral, or chaotic. What do we mean by that? So lawful characters in D&D believe that all deviations from the rules are wrong, period, with no exceptions. In a hospital, think about your regulatory affairs people. Think about your counsel. To be honest, most managers in hospitals are lawful. Then there's the opposite alignment, chaotic. Chaotic characters in D&D think rules are wrong, period, and there should be no rules, and I should be able to do whatever feels right. Think about some of your maverick surgeons. I know you've seen this, right? And then there's the neutral alignment, living in the middle. We need rules. We have to have rules, but no rule is perfect. Life is strange, and sometimes things that are unexpected happen, and it's okay to deviate from the rules in those circumstances. So I'm going to tell you 3 patient stories that inspired this journey. Think to yourself during these stories, are you lawful, neutral, or chaotic? And the reason I'm telling you these 3 stories, yes, they happen locally, but this kind of stuff happens at hospitals all over the United States every day. True story number 1. Patient in the ICU gets better, gets downgraded to a ward bed. The downgrade orders are in, but there is no open ward bed. So the patient is going to board in the ICU for several hours. And during that time, it turned out he needed a PRN medication, and nursing refused to accept any orders for said medication. And I got a call in my office yelling at me from the hospitalist that nursing wasn't taking the orders. Me getting a call yelling at me is going to be a common theme to all 3 of these stories, okay? My office is the nexus of unhappiness in the universe. All unhappy thoughts pass through it. So I called the nurse manager, and I said, why aren't you taking the orders? And she said, we have a unit structured standard. This is a nursing policy. The patient has been downgraded. This is no longer an ICU patient. The ICU docs can't write the order. And yet the hospitalists are not privileged to practice in a licensed ICU bed, so they can't write the order either, so we can't accept any orders. And I was like, are you really serious about this right now? I gotta solve this for you. Go ahead and override your policy. True story number 1. True story number 2. 55-year-old with a lower GI bleed. It is not a rapid bleed. He is not dying. He does not need an emergent procedure. But he needs a diagnostic colonoscopy, not a screening, a diagnostic colonoscopy, and it needs to be done in the next 1 or 2 weeks. He has some comorbidities. It's going to need to be with anesthesia. So the nurse says, who's going to pick you up after the procedure with anesthesia? He says, I live alone. I don't have any family. I don't feel comfortable asking friends to pick me up. I'm just going to Uber home. And she says, unfortunately, hospital policy requires that we know who's going to pick you up for safety reasons, so I cannot schedule your colonoscopy. Now, this patient is an EMT. He has worked as an EMT for 25 years before he retired. He knows how hospitals work. So guess what he does? He calls the CMO to yell at him. And I'm like, all right, I guess I got to fix this one too. True story number 3, I am not making this up. This really happened. 18-year-old kid downtown gets violently mugged. Very violent. Paramedics take him to our trauma center. Orthopedics evaluates him. He has an open fracture. They put a temporary pin in. He is in traction. They say, you don't need an emergency surgery. You're not going to go today, but you need a scheduled operation in the next 2 to 3 days, or there's a risk the leg will not heal properly. They call the surgery scheduler down to the ED. Surgery scheduler comes down. Okay, I need to see your ID badge. Your photo ID so I can schedule your surgery. The kid says, I don't have my ID. My wallet was stolen during the mugging. Oh, that's too bad. Unfortunately, hospital policy requires that I see a photo ID to schedule a surgery. He stops, he's thinking, problem solving. Oh, light bulb. Okay, I got it. Go on down to the DMV, get yourself a new license, and come on back and I'll schedule your surgery. I am not making this up. This actually happened. Okay? So the patient freaked out. The nurses freaked out. They called the orthopedic surgeons, and y'all know what the orthopedic surgeons did, right? Yeah. They called and yelled at me. I'm like, I didn't do this. Why are you yelling at me? I'll take care of it. No worries. I figured out who the scheduler was. I called the scheduler. So listen, man, don't worry about it. It's all good. Go ahead and schedule the surgery. Override the policy. And I'm thinking he's going to say, okay, thanks, man. I knew the right thing to do, but I didn't want to get in trouble. This is a policy violation. That is not what I heard. Instead, what I heard with a tone of righteous indignation. So I'm just supposed to ignore hospital policy when I want? And I was like, well, yeah, when the decision otherwise would be stupid. And this is when I realized we had a real problem, because you see, our staff had become so beaten down by policies that they had developed Stockholm syndrome and had begun to sympathize with the policies rather than the patients. And this was the origin of the policy to override policies, which was developed with risk management and counsel input and created a due process mechanism to allow us to deal with these situations. The policy says that any staff member can override any policy when all of the below conditions are true. First, the staff member has a, quote, reasonable belief that the override is needed to benefit a patient or a staff member. And it defines a reasonable belief as one that is likely to be agreed upon by other similarly qualified people in similar circumstances. This is the first basis of due process. If somebody later objects, this is the evidence standard that is going to be judged to decide if this was a reasonable decision. The override has to be within the normal scope and expertise of the staff member. So pharmacists can't override nursing policies and doctors can't override pharmacy policies, for example. The staff member's supervisor is called and has to agree. So now you see you have two people. It's not just one D&D chaotic person going around doing whatever they want. Two people have a shared reasonable belief, and this is the second leg of the due process mechanism in the policy. The override gets documented, including the rationale for why. The manager of the area is notified so they can consider, should we revise this policy to prevent this from happening again? When the policy went live, it was used 5 or 6 times in the first couple of months, frankly with great fanfare. People were super excited about this. And then it stopped being used. It hasn't been used in quite a while. And so we're talking to our staff, why aren't you using this anymore? And they're like, we don't need to. We're just doing the right thing up front. Ironically, activating the policy gave the message to the staff that we had their back, and they no longer felt they needed to fall back on stupid policies anymore. Now, this brings up an important point, because a common thing I heard before the policy went live was, can you really trust your frontline staff to make these decisions? Shouldn't you be making these decisions? And I've actually heard this from several people across the US since the manuscript was published. And to that I respond, do you hear the words coming out of your mouth right now? Are you listening to yourself? We hired these people. We trained these people. If we can't trust them to make these decisions, we are incompetent at hiring and training. That's on us, not on them. So when y'all are talking about how you want to empower your staff, is that a platitude or are you serious? Because if you're serious, it's time to put your money where your mouth is. Okay? So, bottom line, I admit it. I'm a D&D nerd. Not only am I a D&D nerd, I'm a neutral good D&D nerd. Does anybody else out there want to join me?